Okay, it's 8 o'clock, so welcome everyone. My name is Kate. I'm with Quality Core with the Patient Centered Primary Care Institute, and I'm just going to share a couple of things to you before we welcome our presenters, Jessica and Angela, today to talk about partnering with patients. So we appreciate you joining the webinar today. Since there are a number of you on the phone line, we're going to take questions today via the questions pane in your GoToWebinar control panel. One question I can anticipate from everyone is about the slides. The slides from today's presentation, along with a recording, will be available on the Institute website by the end of the day today, so look out for those. An email will also go to everyone who's attending the webinar today with a link to that portion of the website. Feel free to go ahead and give us your questions as they come to you during the presentation. We have a very full presentation today, so if you think of a question while the presenters are going along, feel free to type it up and send it to me, and I will get to as many of those as we can, as time allows, at the end of the presentations today. A little bit about the Patient Centered Primary Care Institute before we get started. It was launched late last year as a public-private partnership between the Oregon Health Authority and the Oregon Healthcare Quality Corporation. The goal is to offer a broad array of technical assistance for practices that are at all stages of practice transformation. We are hosting a series of learning collaboratives throughout the state. We offer a website, and through the website, things like webinars and then online learning courses that are in development. The Institute works with the Oregon Health Authority's PCPCH program, which is how the state recognizes primary care homes. You can read more about the PCPCH standards, which fall into the 6 core attributes that you see on your screen, at their website, which is linked at the bottom, primarycarehome.oregon.gov. And without further delay, I'm going to turn things over to our panelists today. We're welcoming Jessica, Angela, and Margie to talk to us about engaging patients in quality improvement. Each of them has a unique experience to share with you, and I'm very grateful that they were able to join us to do that today. You want to go ahead and take it away, Angela?
Yeah, thank you so much, Kate. We're so happy to be here to talk to you guys this morning and appreciate you being on our call to share with you about our 2 models of what's been working for us in partnering with patients. I've been the program coordinator for patient and family-centered care here at Providence Medical Group for the last 2.5 years. And Jess, if you want to introduce yourself.
Sure. Hi, everyone. I'm so delighted to join you today and so excited that you're interested in this great subject. I work for an organization called Aligning Forces Humboldt, where I'm the project manager for patient engagement, and I've been in that role for about 4 years. So looking forward to sharing some of our work later today.
Hi, I'm Margie Turner, and I'm currently one of the co-chairs of the Providence Medical Group Patient and Family Advisory Council. And I've been in here for about 2.5 years, one of the founding members.
So we want to go to the next slide. So today we're going to be talking to you again about 2 models for patient engagement that have worked both for Providence Medical Group and for Humboldt, really with a focus on quality improvement in our patients' experience. The first is on how to create and effectively work with patient and family advisors through a council. The second will be a patient partner model, which Jessica's going to be talking to us about today. We're going to end giving you guys some lessons learned from both practices and ways that you can really apply these different models within your own setting. And then we're going to also end with a patient reflection from Margie, since it's very important to hear from our patients and what the experience has been like for them. And then finally with some questions at the end, because we'd like to hear any feedback and any questions that you have and address those today. So starting off, just to paint a picture of where we are from our setting here, we have a multi-specialty group of over 700 providers, over 106 clinics in Oregon, and the real focus that I want everyone to know here is that we have our patient and family advisors who are mostly focused on primary care, specifically with our patient-centered medical home work and programs and tools for patients that engage patients in that model. We have over 39 clinics there. And then just to give you an idea for our physician groups of what's included. So this kind of paints the picture moving forward of where we come from. But I also want to keep in mind that though we are very large, ways that you can apply this in a more rural or smaller clinic setting will be talked about today. So here's the model for our Patient and Family Advisory Council. There are anywhere from 12 to 15 patient and family advisors who are recommended by their primary care providers. The list of different characteristics for what we're looking for really are surrounding an interest in healthcare improvement, ability to share stories about their experiences and listen to other people's stories as well, and just be able to really communicate well with other people around the table. So what you see in the middle are our patient and family advisors around a table. And what's on the outside is our leadership who attends meetings monthly. That's actually our past president. He just retired a couple months ago. But there's involvement from that high level because when decisions are being made about policies and programs, there's both an administrative as well as a clinical perspective that patients can really look to for information. And those lines really represent that relationship between patients back to our leadership and then back to our patients again. It's a constant flow of information and relationship building. The first couple of meetings was really the building the trust. So the patients started out and asked some pretty tough questions to our staff, but they were able to respond openly and were welcoming those questions. And through time, the patients saw that they were really there for because we want to hear from their perspectives, whether they're going to be hard or challenging for us because we're not doing as good of a job as we should be, or because, it's just getting to know each other. It's relationship building in any team environment or any kind of council setting. So they went through a forming stage initially where they got to know each other. Lots of brainstorming happens during this phase where not only patients get to know from one another and their stories and experiences in healthcare, but also from our leadership. And then they went into a storming phase, as groups do, and this is a necessary part of the development for these councils where, people are a little bit misunderstanding maybe of their role or have questions, not really sure what their charge is, since we really want the patients to be the ones who choose and pick the different things that they're going to work on and focus on as a council. So this was a necessary part, but what it's led to is now that they're past that, they've gone into this norming phase and actually into performing where they're able to solve problems during meetings, brainstorm, develop ideas, and really work effectively together. A lot of the leadership attend so many meetings that they say at the end that this is one of the favorite meetings they get to go to. So that makes not only the patients feel good, but it's good for me as the program coordinator to hear as well. Next slide. And so during the development of the council, what happens is we had some different ways that we ran the meeting. Again, there was a lot of need to have relationship and trust building in the beginning. But over time, once they were in their norming stage, they realized the most effective way to run a meeting is really through this 4-step process. So as the program coordinator, I sit on different meetings, and I work in the education department here, so I get a lot of information constantly on different projects we're working on and policies we're working on, and then ways to engage patients in that work. So I'm always talking about the council and recruit and promoting the work that they're doing, and then there's been a ton of interest that's come as a result. Patients themselves come with me and do presentations at various meetings. So now there are a list of different projects constantly that we bring to the meetings. So we'll have, for instance, this is a picture of our physician education coordinator and physician education leader who were talking to the council about what was the most effective parts of the relationship between themselves and their primary care provider. That information was then brainstormed, and ideas for quality improvement in that area were put on, as you can see, some Post-its. And then these ideas were used for the program as it continued to develop over time. It's always very important, of course, too, to follow up with the patient and family advisors, and we're going to talk a little bit more about that later in the presentation, but it's key because it not only keeps them coming back, but then they can actually see and we can show results not only to patients but to the rest of Providence Medical Group leadership and staff so that they can see that our patients are truly making an impact on our organization and quality improvement efforts. Next slide. So from those meetings, what you'll find is sometimes an idea for whatever's presented to the patient advisors is so big that they end up developing a subcommittee outside of the council time. So the council meets in the evening once a month for 2.5 hours with dinner served, but out of that 2.5 hours, it's not enough sometimes to tackle the projects that they come up with. So our patient and family advisors will meet outside of those meetings with leadership around the table in order to discuss further how to improve upon a process or program. So here's a list of some of the ways that our patient and family advisors have done that. They first got really interested in after-visit summary usage and how to increase that. Half the council raised their hands, had said that they received one, half had not. And so because of that, they were charged with, hey, every patient really deserves the ability to at least be offered an after-visit summary, which lists a bunch of information on their visit that day and how to best follow up and take care of themselves as their family member. Then actually over a campaign period, 3 months later, posters were put up in clinics created by our patients, and there was a 29.9% increase in the usage of after-visit summaries, which is pretty significant. We're so proud of our patients and able to share that information, again, out to our Providence Medical Group staff and leadership to show that our patients are truly making an impact. On the next slide, I'm going to talk to you about another subcommittee where they formed an agenda setting form that's now being used across the state of Oregon. So how that works is patients, again, around the table at a council meeting, after the agenda or the after-visit summary project was completed, said, well, hey, what are we giving our patients when they come into a visit to engage them during that visit with their provider? And so they raised their hands. Half had received, again, or over half have received an agenda setting form at check-in, and others had not. And so they started to get interested in, well, what are we giving our patients, and is there a variation in these forms that are given between clinics? So I sent a survey out to all the clinic managers in Oregon, and here's the response rate. So 18 were not giving the form out, 11 were giving the form out. However, out of those 11, those forms varied quite a bit in the content and style and size even. Some were 3 pages long, some were even hard for us to understand as healthcare administrators. So it's something that really was needed to be looked at, and our patients were the reason why we found out that this was something to really focus on. So the subcommittee formed. They met based on schedules that worked for everyone, so it was actually an evening meeting just for an hour and a half, and they met several times. We choose a patient and family advisor to be a project lead, and so we were lucky to have that project lead who really helped charge the agenda and keep the focus during the meeting. So what they did is took all the different variations of forms for agenda setting and decided upon the ones that they felt were the most useful for patients and easy to understand and effective. The form was then, we worked with our health educators as well as our providers, and the form was then finalized. They also said, well, why don't we take it to one of your quality improvement groups? And so they took it to our service improvement group and got feedback from staff, multidisciplinary, from different folks who work in the clinic on their ideas for the form. They really wanted to make sure to involve everybody in this process. They also said, well, how are we going to communicate when you have so many clinics what this form is and why it's important to patients and how to maybe use it? So we actually created a video. And that video is something that is on a SharePoint site where folks from across the state of Oregon can pull it up and show their staff during all staff meetings. It shows an example with our patients. Margie actually is one of the stars in that film, working with actual clinic staff at Bridgeport Clinic here in Portland on process, how to hand it to a patient, the rooming process from a medical assistant's perspective, and then the provider who comes into the room and uses the form with the patient. And when we showed this to all of our leadership initially, all of our medical directors and clinic managers, we showed the video and they all just raised their hands and said, we just want to thank you. It was really a win-win they felt for both themselves as providers as well as for the patients, knowing that this form is something that is useful. It's going to be helpful for our providers also because it's going to make sure that they really get the concerns addressed during that visit, and any complications or issues that have occurred in the meantime are addressed during the visit as well. So here's the form, and I want to point out at the bottom there's a logo that says Providence Medical Group Patient and Family Advisors, and that has a check mark on it. Actually, it's Patient and Family Advisory Council, so that other patients can see that this is made in partnership with patients and something created, in fact, with the patient's viewpoint in mind. And I'm going to turn it over to Margie, who's going to share a little bit about what it was like being a part of this subcommittee to create this form that's now being used across the state of Oregon.
So what's really nice about being part of a subcommittee is not only do you have your other patients there with you, you also bring in doctors, administrators, and those types. And what's really was fun about being on this agenda setting committee was to have a doctor who was extremely passionate about not only the patient, but about giving the best care for the patient. So he was really able to speak into a lot of this form and actually had been using kind of a similar form. But as patients, it was really great to get together and have different ideas about what was important to us as we went into a visit. And one of the things was, believe it or not, we spent quite a bit of time and a little bit of a fight to get to help ease your way. We really wanted the patient to feel like this was a form not that Providence was asking us to fill out because they needed more paperwork. There was a form for us to fill out to make today a little bit easier with our appointment. So being part of that process and being part of the table discussion and having people that were not only just patients but also Providence medical staff on this subcommittee really enhanced the process, made us feel like we were being heard as patients. And I even feel like the physician on the board, on our little subcommittee, really felt like he had a lot of input in helping us with this. The other thing is why this is important to me, why serving on this council is important to me, why being part of even subcommittees are important, is I really have a desire to make a difference in not only my health care, but my husband's health care and then my in-laws' health care, as I represent pretty much 3 generations of individuals on this council. So when you bring patients on board, you not only bring just that patient, but you also bring their family.
Yeah, and really serving to our broader community. They touch the lives of thousands and thousands of patients every day by these different ways. They've created ways to really ease the way for our patients during visits and improve different programs and policies for us.
And what's also nice, too, is that not only is this being used in the primary care setting, but they're also looking at using it in immediate care and specialty.
Yep, that's in process right now. Thanks, Margie. So the leadership's role in all of this is critical to any success, not just understanding what, the idea of patient and family-centered care, but really being able to walk the walk as well. So what I'll do initially, and what I did a couple of years ago, is presented on this idea of patient and family-centered care. And this is a quote from the Institute for Patient and Family-Centered Care. I went initially to a conference there and was able to learn a lot about ways to build these types of programs in a setting like a medical group, and was able to bring those learnings back to my own setting. I would recommend looking at their website for information. And really just presenting to leadership on what the idea is, but then also bringing patients in with me to share their stories was really an effective way to start off that relationship with our leadership and really building partnerships with our patients. So just making sure that keeping an open mind, sometimes when you think of an idea about how to solve a problem, then you get a room of, or a bunch of patients in a room to ask them. The ideas are much different than what you had been thinking. So having that open-mindedness is important. Also being able to share information in a way that's transparent. We give all of our patients all of our scores on quality and patient satisfaction, and really want them to know that this is an open and honest relationship from the very beginning. Being flexible, knowing that sometimes we need to bend in certain ways we hadn't anticipated is important as well. Again, they come up with different ideas, and we just go with that. And as you know, walking that way with them in that journey has been something that's been really made an impact on our organization, and really has started a culture change here for the patient and centered medical home and the patient and family centered care. And also being supportive, coming to the meetings, showing up, but also just encouraging different projects, supporting different ideas in meetings. A lot of our leadership talk about these programs and about the Patient and Family Advisory Council in other meetings. It's something I hear about all the time, that this story came up or this story came up during a meeting about our patient advisors and the difference it's making in our organization. And being committed. Again, they're being present during those meetings is something that shows our patients that this is not just checking off a box. It's something that we truly are passionate about as an organization. So the patient and family advisor's role within our organization is really about partnership. We want to build relationships and encourage them from the very beginning in understanding why this is something we're passionate about and interested in really truly hearing their perspectives and insight, because we want to know. It's something that's important to us. Keeping an open mind when other patients and leadership and staff sit around the table and have different ideas or opinions than they do, it's important to keep that open mind on the patient advisor side as well. And then seeing the big picture, knowing that this is part of we've given our patient advisors on the council a lot of information on big picture changes in primary care and redesign, just so they're aware of what the patient-centered medical home is all about and why it's happening. And also just getting to see the big picture of the culture change in our organization and shifting into that medical home model and what their role is in it. And being our advisors, so this is different from being an advocate. We're really wanting to know ways to improve different processes again, and so it's really an advisor role, and we set the stage for that from the very beginning. So the patient and family centered care role, which is my role, is really to oversee the program in these various ways and ensure that our patients are supported along the way. That starts with recruitment, just making sure that the explanation of what this role is very clear from the beginning. Adhering to the different HR requirements for volunteers is something to check out right away before you get started, to make sure that you're keeping those personnel files and making sure that you're doing all the background checks and everything that you need to do. Having the training and orientation, I have a training and orientation that's very similar to what we do for our new employees at Providence. So they learn all about our mission and history, vision and core values. They get HIPAA training and an ID badge that says Patient and Family Advisor, because they're truly treated as part of our family here at Providence. And support for the clinic leadership team. I am answering questions on ways to encourage more patient engagement within the clinic settings, as well as engage them within the council, and also being supportive to our patients, constantly answering questions, meeting with them, really just supporting them in any way I can to encourage their coming back. And we've had a very great amount of retention. We've only lost a couple patients in the past 2 years, and they're just really excited to be there. They show up every month, and we're very grateful for that, or even more than every month. Now I'm going to be turning it over to Jessica.
Great. Well, thanks, Angela, and thanks to Margie. Just before I kind of launch in the background, I'll say that when you're involved in this work, it is so exciting and it's such a privilege, but part of it is doing a little bit of bushwhacking yourself, figuring out the model that works best for you. And certainly my work has really been enhanced over the years from working with Angela and learning from Providence, and as well as other colleagues around the country. So certainly a pleasure to be presenting with you today. A little bit about Aligning Forces Humboldt. So I mentioned before that I work for an organization named Aligning Forces Humboldt. We're actually part of an initiative called Aligning Forces for Quality, and that's a healthcare program funded by the Robert Wood Johnson Foundation. And if it sounds familiar, it's because actually Oregon is a recipient of one of the Aligning Forces for Quality grants as well. So we're Oregon and Humboldt are both representatives of 16 communities across the United States that have really been tasked to convene payers and providers and patients to improve the quality of healthcare at local, regional, and national levels. And so our focus at Aligning Forces Humboldt is to really generate meaningful opportunities for patient engagement in healthcare improvement. And certainly for AF4Q, this has really been, the AF4Q platform has really been what's launched our efforts with consumer engagement and patient engagement work in Humboldt. Okay, let's see, next slide, please. Okay, so our work with patients in quality improvement and practice redesign efforts started in 2011 as part of a larger 12 to 18 month community-wide primary care collaborative. And that collaborative is run and was run at the time by our Independent Practice Association. So in Humboldt, we call this collaborative project Primary Care Renewal, or PCR, lands of the acronyms that healthcare is. And we based, we based our collaborative in Humboldt on the Care Oregon model, so that may be familiar to some of you. When our IPA started the collaborative in 2008, we had about 12 different practice teams, and they were all primary care practices. The practices range in size from a multi-clinic site FQHC to really tiny 1 to 2 provider independent practices. And the collaborative really started off with the basics. So what's quality improvement? What's a PDSA? What are aims? How do we do run charts? And so as the collaborative matured and as we thought about doing second phases of the collaborative, in 2010 we decided to focus on the patient-centered medical home model. And since we were really going to be encouraging patient-centered redesign, we thought it was imperative to have patients at the table. So planning in 2010 and initiating in 2011, we decided to bring patients into these quality improvement teams. So we developed a model where 1 to 2 patients could be recruited per practice quality improvement team. And since it was our first sort of foray into working with patients in redesign and quality improvement efforts, we really wanted it to be, an approachable concept for really, really small practices that might not have the infrastructure to support a broader council. And Angela, I heard mention in her presentation that there's really an emphasis on advisor. And so when we went and really deliberately recruited patients to be involved in the project, that was something we made really explicit, that we really encouraged patients to share insight and feedback explicitly on collaborative topics and explicitly on the experience of care in their own office. Okay, so you just caught sort of the large narrative history there of the involvement of patient partners in Humboldt. This is a much more kind of visually digestible snapshot of our project structure here in Humboldt. And so what you see on the outer circle there is the primary care renewal collaborative. So that's the larger context in which all this work takes place. These are this is a collaborative that's 12 to 18 months in length. The meetings happen once every 2 months. As part of the collaborative, there are practice teams from the community, and these are from 10 to 18 primary care practices, depending on the collaborative itself. And then in each of those 18 practice teams, there are 2 patient partners. So each team involved recruits 2 patients to be full members of their effort. Okay, so this gives you a snapshot of the major stakeholders involved in the patient partner project and their roles. So first of all, we have the PCR teams. And usually these teams are about
6 to 8 members in size. They're composed of staff in the individual primary care offices. We really encourage folks to have a blend of providers, front office staff, back office staff. They work on really specific aims, so each collaborative usually has a theme. I mentioned the one on patient-centered medical home. We've also had a collaborative on access. But they also set specific aims to their office. These teams meet 1 to 2 times per month, and they recruit and involve 2 patient partners in their teams as members of the teams, just as a provider or office member would be. In addition, they do attend those collaborative meetings that are held once every 2 months. Then, of course, we have the patient partners. So they are the members of there are also members of the practice team. They attend team meetings, collaborative meetings, and then patient-only meetings, which we call patient partner meetings. And I'll get into the functions and purpose behind all of those in a moment. And then they bring forward the patient perspective of care on key focus areas. And they do it at a global level related to the topics of the collaborative, and then at a really granular level related to the aims of each of the teams. And finally, we have the coordinator, which is me, my role. And I don't work directly for any of the practices. I work for the Aligning Forces for Quality grant. And so in my role, I really help with the recruitment of patient partners, the development of the project. I do a lot of training and orientation. And I also serve as the liaison for both the patients and the practices as they kind of walk down this journey into this new relationship together. Okay. So just earlier we saw the slide with all the concentric circles, and if you were to put a microscope just on the patient-partner part of the project, this is what you would see. And so in our effort here in Humboldt, patients are actually engaged in 3 different ways. They attend those collaborative meetings, which everyone in the entire collaborative project attends. They attend team meetings, which are the practice meetings just at the office, and then they attend the patient-only meetings. And you can see that this is, again, taking place in the context of that larger quality improvement project. So engagement in team meetings. In Humboldt, what this looks like is 1 to 2 team meetings per month with the practice. They're approximately an hour in length. This is the time where the teams that are in the primary care collaborative get together and work on their team goals and track their progress towards larger collaborative goals. To kind of translate this to what could look like for your experience in Oregon, you might have quality improvement meetings that are already taking place in your office. You might have a task force or a group that's working on a set of projects. You might have microsystem team meetings or even a staff meeting. And this might be equitable to a way to apply what's going on into Humboldt into your practice in Oregon. So the purpose of patient involvement in this meeting is really to bring forward their perspective as a patient of the practice. And again, we really support patients to really focus their attention on team goals and the experience of care in the practice. Patients are involved as members of the team, and in many cases, practices will have an agenda and a standing agenda item to make sure that the patient voice is heard throughout that meeting. In these efforts, in the team meetings, the patient partners are supported by a liaison at the practice. In our collaborative, we have practice coaches that attend team meetings, and so they really support the coach. Co-patient partner, we really recommend that you recruit at least 2 patient partners because folks find a lot of support in working with their colleagues. And then tangentially, I support patients in their engagement in these meetings. I will mention that identifying a liaison at your practice is probably critically important. This will just be a key contact person that would really be there to answer any questions that your patient partner might have, help them, troubleshoot anything that comes up, make sure that they're aware of upcoming meetings, make sure they're comfortable with team goals, et cetera. I think that's a really critical position. So here's some of the outputs of engagement in those team meetings or small practice meetings. We've had patients work on practice brochures. We've had them test patient portals. They've done patient surveys. So one example of that is that we have a pediatric practice, and they were noticing that a lot of people were declining immunizations, and so the patient partners, along with their practice team, designed a survey to understand what the parent barriers were to having their children receive their vaccines. They work on system redesign issues with their practice. So as the practice is redesigning a process, they often vet it through their patient partners to make sure that it's still comfortable. They do a lot around communication and marketing. So our most recent collaborative was focused on empanelment, and there was a lot of discussion about how do you talk to your patients in your practice about the process of empanelment without making it feel like you're assigning a patient to a specific provider. And so patients crafted a lot of patient-friendly language around those sort of issues. And also they're just as involved as any of the other team members in influencing those kind of tests of change as part of larger collaborative efforts. In Humboldt, we use the Plan, Do, Study, Act cycle, which is why that is pictured there. I will say that if you're starting this work, it's really, really valuable to have a couple projects off the bat that you think that you might want to include your patient in. We actually kicked off all our patient engagement efforts with the practice brochure, so having patients along with their team design patient-friendly brochures that identified and articulated kinds of critical to know language, and that really helped foster that relationship, especially since it was so new working together in that way. Okay, so I mentioned we also have patient-only meetings, and to translate this to what this might look like in Oregon, this may be something like if you do decide to have a key staff member, they're designated to work with the patient partners on your team. This might be something like a small meeting that you do on an individual basis with your patient partners. It's an opportunity to give your patient partners time to debrief and talk through any questions they might have, address any concerns they might have with a trusted member of the staff. In Humboldt, we have these meetings every other month. They're 2 hours in length. We actually hold them the evening before the larger collaborative meeting, and we use these meetings to introduce patients to key content areas that will be addressed the following evening. So on the evening we talk about empanelment, we introduce our patients to that ahead of time. It's also a place where we do a lot of debriefing, asking questions, having patients share the challenges that they've experienced in their teams, and also share successes. We've seen during those meetings, since we're getting all the patients together collectively, that they often share ideas across teams that don't translate in the larger collaborative. So that's been a really exciting, actually, development in this work. They are collectively offered insight in content areas in this meeting. We do a lot of brainstorming and problem solving as ways to kind of elicit their perspective. We also make sure that we really capture their perspective on the large issues of the collaborative of this meeting. So when we were talking about advanced access, we talked through we approached our patient partners with challenges that they were having, encountering, getting a visit or issues with the telephone system, and then we're able to bring that back to the collaborative at large from a more global perspective. This effort is really supported by me, the project coordinator, and the output is really prepared, confident partners. Okay, and finally we have kind of engagement in this broad conversation. For us in Humboldt, this is their participation in the collaborative meetings. And these are the meetings that everyone that's involved in the project attends. They're every other month, they're 3 hours in length, and they focus on those sort of key content areas of the collaborative as a whole. We want them to participate in those meetings because, again, they're full-fledged members of the team and all team members attend this. But they also have kind of, it's developed where they've been there to present the broad patient perspective across the community of stakeholders. So I mentioned in the patient partner meetings that we do a lot of discussion and gathering of their insight on sort of more global topics, and we share these back to the collaborative at large at the beginning of each meeting. We've really found that this has sort of set the tone by having a standing presentation on the content areas. The presentations have really varied in format, so sometimes we do a skit, sometimes we have people share their stories, sometimes we do interactive games, and we've done evaluations on these activities at the end of each collaborative meeting, and they're really well received, and people do feel that they really set the tone for the evening. Okay. Oh, and if you were to do something like this in Oregon, I realize not everyone is functioning in the context of a larger collaborative, but you may have a community meeting that you're working on, or patient or community meeting, or a large collaborative thing going on, and patients can really offer valuable feedback during those events and really set the tone for productive work to take place. Okay, I'm going to turn it over to Angela.
Thanks so much, Jessica. And you have also provided us with so much knowledge. I want to just thank you for all of your great work over the last years and helping us to figure out ways to build our patient engagement programs here in Oregon. So some of the lessons learned, I'm just going to briefly show you this list. This is something that Jessica and myself and Margie, our patient advisor, came up with. From her model and from the council model, what has really been really critical to share with you guys in starting these types of programs or maintaining them over time. So next slide. So having leadership support, again, I know I've said it before, but it's so important to really make sure from the very beginning of this work that you have your top leadership on board and in support of these efforts. And here's a picture of our patient and family advisor, Sam Wise, who is showing our Chief Executive Officer, Dr. Joe Seminzik, one of the projects that we had completed and our patients had completed on the council, being able to share and collaborate together. Again, I'm going to stress the relationship building has been so important between our patients and our leadership. And it's really allowed for that conversation to go in areas and directions where changes are happening because there's so much trust and support in both the patients and from the leadership. So having clear roles, and Jess, you're going to take this one. So, but I do want to just stress that the clear roles and expectations has been important on our side as well.
Yeah, and so one of the things that's been really great about working with Angela over the years, even though our models have been different, a lot of our takeaways have been the same. And so for Humboldt, having a really kind of explicit role set up for your patient partner and very clear expectations from the front, from the beginning of the process, have been really critical to our success. So we sometimes employ an interview intake process. I know that's something that happens at Providence. Again, having an idea of projects or areas where you want patient input from the get-go is critically important. You should be totally upfront and transparent about the processes. Are patients there to be decision makers? Are they there to be advisors? And then you should also really communicate expectations up front. What you see to the right there is a patient partner role and responsibilities agreement, something we've developed here in Humboldt and on patient partner roles. It really models actually the contract that we had practice teams sign to participate in the collaborative, but it explicitly sets out how they're to be participate fully, be informed and empowered, listen, speak up, collaborate, and be respectful of other opinions. All right, next slide.
Orientation and training. As a patient family advisor, I think that was one of the most important things that Providence could provide for me as a patient was what was Providence, what were their goals and expectations of me as a patient, and also some training and resource binders. Resource binder was perfect. Any type of thing from the meetings, anything from the code of conduct to the AVS. Everything that I need for a meeting, I put in this binder. I have contacts. I know the other patient and family advisors' email addresses. Those things are really important. Orientation to Providence Medical Group was very important to me. I've been a patient for a little over a year. My husband a little bit longer, my mother-in-law longer than that, and I was familiar with the hospital system but not with the medical group. And so understanding the core values really helped me focus on, okay, this is an organization that I want to be a part of and that I want to make a difference in. Also access to a trusted team member. So having Angela on staff, having somebody who is dedicated to your patient and family advisors is extremely important. We wouldn't have the success that we have after 2.5 years if it wasn't for the fact that we have a program coordinator, is that we have somebody on the team that is part of the Providence Medical Group who is our guidance, who is our leader in a lot of sense, who helps guide us through the process. If we had everybody from all the departments just decide to come to one of our meetings at one time, it'd be total chaos. So having that leadership from inside is extremely important.
Thanks, Margie. So providing the, getting the input from our patient and family advisors on different projects and policies, again, has become something that's pretty popular among our medical group. And I want to stress the presentations and sharing what the idea of patient and family-centered care is, how it will be effective in your medical group or whatever setting you're in is critical. And then over time, you get to present on all the projects that are being completed, which is also important to get folks engaged and help facilitate that culture change in patient and family-centered care. So what you see here is a form that was created after a couple months of doing this work. I realized the need to have there be some type of contract for individuals from different programs and departments who wanted to get patients' feedback and input. So you'll see that there is asking for a history of the project, why they think it's good to include patient and family advisors in the project, and what expectations they have. There's also a deadline and a desired deadline date here, as well as what things are really negotiable and what are non-negotiable. That's very important to set up from the beginning. What this will do is set staff up to be successful, as well as our patient and family advisors, having a really clear idea of the background, the history to the project, and ways that they'd like to work with patients moving forward. Also, again, things that can change and things that can't, because not always are patients going to come up with things that we can actually apply to that different project. So having them know that from the beginning is really effective and helpful. Also, you can see it, there's a signature line at the bottom with a date. This is the critical part, I feel, so that individuals are really signing that they're going to be following up on how the patient and family advisors made a difference on that project. So, for example, we recently had Elder Place come and presented to our council on a poster that they're going to be putting up in some of our primary care clinics. They got a lot of feedback. That was very helpful. We're very thankful to get all the feedback, and now they're making changes to that poster based on our patients' feedback, and we'll be showing them what that poster looks like in the next month. So, again, the follow-up is critical. You have to have it on both sides for the staff to understand the importance of how we're taking this program and our patients, as well as for the patient side.
Okay, great. And so Angela really touched on this, but we felt that it was worth emphasizing again, just having that deep commitment to the transparent feedback loop. Boy, nothing undermines a project more than asking for someone's perspective and input on something and then having it go nowhere. So what we found in our work with patient partners in Humboldt County is we'll be brainstorming around a process with them, and someone will say, well, I'm having a really hard time with the practices phone tree, and the phone tree, they should just get rid of the phone tree, and they should have a live person answer the phone all the time. And so what we've done is had a real commitment to transparency around the kind of financial and practical issues of running an office and saying, well, I can understand that, but, you know, there might not be the money to support changing that, or, boy, phone tree systems or practice answering systems are really expensive and funds might not be allocated. And patients totally understand that. They're actually there to be your advisors, but in many cases they're your champions as well. So just I would say be willing to talk about those really true political, financial realities of your situation. It really helps support the relationship with everyone involved in the project. Okay, next slide. Okay, so these are some reflections of folks that have been involved in our various projects, and really we get a lot of qualitative feedback about the meaningfulness of this work, so we can see a quote here from Dr. Ben LeBlanc, who's the CMO at Providence Medical Group, and really how important the advisory council is and the amazing accomplishments it's making. We need to have all our providers be exposed to what they're telling us because it's transforming the way we think about the care that we provide. And certainly that's really synonymous with some of the feedback we've had here in Humboldt, where we hear things like, you know, practices really struggle with the fires of their day, but having patient partners involved really keeps patient-centered care at the forefront of the discussion. Another clinician said they keep our focus centered where it should be, which is on the patient. All right, next slide.
So our Patient Family Advisory Council has been going on for 2.5 years now, and I've been a part of it since the very beginning. I've seen this grow from the first couple of meetings having staff involved, and all of a sudden having even Dr. LeBlanc be in one of our meetings, and we started having this discussion about the AVS, after visit summary, and his stance went from leaning back in the chair, kind of enjoying the conversation, to drawing his body inward at the table to really listen to what we had to say. Couple of things. Leadership is important. Having your staff at the table with the patients is important. It speaks volumes to me as a patient. It speaks volumes to me as the CMO or the COO or the CFO comes to these meetings and they listen to me as a patient, or they listen to any one of our patient family advisors. As Providence Medical Group is going forward, and as our council has grown and evolved and developed, we're now getting into the clinics where we're going to be putting a smaller council into a clinic with 2 to 3 patients, working with the medical staff there and the office staff. It's very, for me as a patient, I am excited when the doctor, when the clinic, when the medical group wants to hear my opinion. Even now when I go to my own clinic, the clinic manager, she jokingly says, but I think part of truth is that she always goes out and checks the waiting room to make sure that it's cleaned up and straightened up, because I had made a comment one day when she asked me what I thought about the waiting room, and I said, well, it's rather cluttered, and I don't know what you want me to focus on in there. So just as a patient, having Providence Medical Group, having the Bethany Clinic, having the doctors and the staff here listen to me as a patient has been fabulous. And I encourage you that if you're not listening to your patients now, to go ahead and do so, because I think it's going to make a world of difference, and I think it has here.
Thank you, Margie.
So do we have any?
So now we're going to turn it over for questions.
Hi, this is Kate. So just a reminder to everyone on the line, if you have questions for our presenters, you can go ahead and type those into the questions pane on your GoToWebinar control panel, and we'll take as many as we have time to today. One question that I already got was about getting a copy of the slides, and a copy of the slides and a recording of today's presentation will be posted on the Institute website by the end of the day today. And then we will also email a link out to everyone who's attending the webinar today, so you'll be connected to that. The first question is for Margie, actually. It was about what was the most challenging, or what is the most challenging part about participating as a patient, either in your own experience, or what do you think is the most challenging things for patients who are participating in these kinds of groups?
I think the biggest challenge had been and continues to be sometimes is just learning to develop as a group of patients working together. We all come from such different backgrounds and such different parts of our city that things that affect me over on the west side of Portland are different than maybe would affect somebody in the northeast side of Portland. So it's learning how to work together. It's kind of that storming, forming, and norming phase that we went through. That's probably what I would say is the most difficult.
Okay. And what, maybe Angela or maybe Jessica, you can speak to this, what kind of things can groups do to address some of those challenges?
Well, one thing that we did in the first few meetings is I would facilitate the meetings, and that's important to know. Eventually, over time, your charter will be developed by your patients, and then the patients will elect co-chairs, and those folks are the ones who facilitate alongside with my help when it's needed. So what I did as the facilitator is I had individuals in the very beginning share their stories, and just getting to hear, as Margie just mentioned, the diversity between different perspectives and settings and backgrounds from what they've gone through in our healthcare system to what their families have gone through. Allowing there to be a lot of icebreakers, allowing for not just our patients to do icebreakers, but all of our leadership did them with our patients. So they really got to start from the beginning in developing those relationships. Also going over what the roles are and expectations, and establishing team agreements or ground rules was really critical to their success as well.
And then Jessica, did you have anything to add to that?
Yeah, I guess I would say that since we have patients that are working in different practices across the community, we just really encourage them to bring their perspective to the table, realizing that they might have a different experience than other patients, and just really ask people to, uphold the integrity of their experience, and also acknowledge the value of other people's experience, and to kind of guide in a global perspective about what it's like.
You're a little bit quiet, Jessica. Maybe it's like the phone.
Sorry about that.
Oh, that's much better. Can you just say maybe the last sentence or two that you said?
Sure. So we're in many cases trying to capture a more collective global perspective of care, and that sometimes includes different experiences, and so we just encourage those to come forward.
Excellent. And then there was a question for Angela specifically about the patient form that you showed in your presentation. And the question was about if your team considered including a question that would just ask how things are going for a patient at that current moment, like asking about stressful life events or addressing overall quality of life or general happiness, and whether or not you talked about including anything like that and what the pros and cons of that might be.
So again, our patients were the ones who really created that form, looking at other ways that it had been created and used in the 13 clinics that were using it. And from that, they pulled all the pieces and actually created a new piece at the bottom that asked the patient about any changes that happened in the last visit. I think that their focus was really there, not just for healthcare changes, it was lifestyle stuff that's come up too. So that is addressed at the bottom of the form, and something they felt would be really helpful as we continue to always focus on preventative care and ways to catch things and encourage patients to build that trusting relationship with their care team, and getting to just hear a little bit more about their story and their situation. So if you look at the bottom of the form, it does say, please list any changes to your health since your last visit. So I think also that our patients felt that they have their own stories and experiences of going in to see their primary care provider, and then having forgotten to mention that thing that's happened or life event that's happened or different thing that's changed, which if they would have, could have prevented them from going into the ED or getting sicker than they needed to be. So that was a big part of the form.
Excellent. And I think there's just time for one last question, and then just a quick reminder to everyone on the line, there'll be a short survey that pops up after the webinar. We really value the feedback that you're able to provide, so please stay tuned for that. But the one last question is, what sort of training or coaching is provided to clinic or medical group staff as far as their interactions with patients that are serving as advisors?
I'll take that one first. So what I want to make clear is we are now spreading this out to the clinics. So they received a 4-hour training on the history of the Patient and Family Advisory Council in our setting, the success stories, the projects, how we partnered successfully with our patients, ways that have worked really well for us to encourage them to do the same as they're going to be growing their own councils for CPTI. So having that overview from me of patient and family-centered care, the work we've done, the success we've done, and how it's worked. But what was really effective, I think, was hearing from our leadership who attended that training, as well as from our patient and family advisors who had been a part of this work for so long. They came in outside of the council time and presented on, here's some tips and tools for ways we see this being successful for you. I also created a SharePoint site, so it's an internal website that has little buttons, so it's recruitment strategies, different projects you can focus on at your meetings, different brainstorms, different icebreakers, things like that, as well as ways to ensure that we're tracking and monitoring the different quality improvement initiatives that will start occurring at those clinic settings. So that's how we did it.
And looks like you guys had one more slide, so I'm going to let you guys cover that really quickly because it is 9 o'clock.
Sure. So I guess we'll just leave you with this parting thought that certainly this is a guiding principle in Humboldt, and I think from talking with Angela probably through her work as well, that putting patients at the center of your care is really an active role in all parts of care, and it's not tangential. And we hope you can carry that work forward. Those are the wise words of Dr. Berwick. So thank you so much for having us today. It's been a pleasure to present to you.
Excellent. Thank you so much, Jessica and Angela. If there are any other additional questions, I will follow up with those with them individually, and I'm able to get back to people via email. And I hope everyone enjoys their day.
Thank you.
Thank you.